The incumbent of this lectureship is Professor Dan Brock, currently the Francis Glessner Lee Professor of Medical Ethics in the Division of Medical Ethics in the Department of Global Health and Social Medicine at Harvard Medical School. And until recently, he was also director of the Harvard University Program in Ethics and Health. So given the occasion, I was going to give just a slightly longer introduction than we normally do, and begin with a brief summary of Professor Brock's career. Probably not many of you know that he originally intended to become an investment banker. He graduated from a bachelor's degree in economics and moved on to NYU in the Graduate School of Business. But perhaps swept up in the activism of the 1960s, he recognized that questions of morality and justice were infinitely more important, not to mention more interesting, than leveraged buyouts, mergers, and acquisitions.
But not more profit.
For sure. Well, that is probably for sure, yes. But with the wisdom of that, he enrolled in the philosophy department at Columbia University. After completing his doctorate, he joined the Department of Philosophy at the University, and he spent more than 3 decades there, building a strong department and an illustrious career. By the late 1970s, his academic interests had turned to bioethics, where he quickly established a national reputation. In 1981, he was appointed staff philosopher to the President's Commission for the Study of Ethical Problems in Medicine under the Reagan administration, where he wrote substantial portions of the 3 volumes that were published during his tenure. 10 years later, he was called back to Washington to serve as a member of the White House Task Force on National Healthcare Reform under President Clinton. And more recently, he has been elected to the Institute of Medicine, one of the most prestigious honors that you can have in the profession. Dan did something else during his tenure at Brown that was decidedly unusual for philosophers of his time. He made the acquaintance of a number of physicians at the university, including our own Lachlan Farrow, who is seated back there. And he began to venture into the hospital and onto the wards, making rounds. Along the way, I'm sure learning more than a little about the practice of medicine, but most importantly, coming to truly understand and appreciate the medical and moral dilemmas that physicians face. Combining his astute philosophical mind with his apprenticeship in medical practice, he quickly became one of the most respected scholars in medical ethics. And I've looked at a number of syllabi in undergraduate and graduate programs in medical ethics around the country, and it's astounding how prevalent Dan's articles are, really covering every aspect of the field. In 2002, after more than 30 years at Brown, he accepted an offer to join the Department of Clinical Bioethics at the National Institutes of Health as a senior scientist, where he was a beloved mentor and colleague to many of the department's staff and fellows. But after a little dust-up with governmental authorities over issues of censorship and academic freedom, which I'm sure he would tell you more about, he decided to move on to more accommodating academic pastures. And so in 2004, we were fortunate to persuade him to come to Harvard, where he has remained since. While here, he has again opened up new areas of research in bioethics, expanding his focus to include exploration of population-level bioethics by founding and leading the new Harvard program in Ethics and Health, a program that has been remarkably successful at training the next generation of experts in bioethics and public health. So I really can't imagine anyone more qualified to deliver an address that he has chosen, the future of bioethics. Please join me in welcoming Professor Dan Brock.
Thank you, Bob. I'll tell you later, but that's a nice introduction. I have to turn this on. So I want to start with an apology because I know at least some of you may have expected to hear this talk a month ago, but I was ensconced in a bed in the Brigham and not just taking a nap. So we delayed it a bit. I'd also like to just express the gratitude and honor I feel to have been chosen to give this lecture. It's quite a distinguished group of previous lecturers. I'm sorry I bring it down a bit in distinction, but nevertheless, it's a pleasure to join them. Finally, I want to acknowledge Dan Wickler, who, from the School of Public Health, who's sitting right here, who I've worked with on most of these issues. He's been a collaborator on them. So let me start. Current medical ethics, what gets done by bioethicists doing bioethics, has a clinical focus to it, and most of you know that. It focuses on the issues that arise in interactions between physicians and other health professionals, but more particularly their patients. And they're familiar issues now: confidentiality, informed consent, who gets to make decisions, surrogate decision-making, and so forth. The other thing it does is, in the research context, where there's also substantial bioethics work, it focuses also in a clinical sort of way. It focuses on work focuses on issues between research subjects and researchers. There is some, as I note on the slides, some additional public and professional fascination with new technologies. One of the latest is stem cells. There's now a lot of interest in neuroethics and fMRIs and so forth. How often the issues that arise there are actually new issues is, I think, problematic. So that's a one-slide picture. I still think of them as slides, but that's a one-slide picture of what things are now. My talk is about what they will be in the future. So what might they be in the future? And you've been brought here under false pretenses because you probably thought from the future of bioethics that I was going to predict what it would be. And not being a predictor, I thought Clinton's healthcare reform would pass, so you can tell how good I am at predicting. I'm going to understand this as a normative issue. What ought bioethics to include in the future that it hasn't included much up until then? Now, the one thing that should be said right at the beginning, it will and it should include a lot more of what has gone before. The clinical focus isn't going to go away. I don't think it should go away. It will be here. We will have new clinical dilemmas that will arise, and bioethicists will be asked to opine on them. But what should be relatively new? What should it include that would be new? I think I've mastered the clicker now. So, and what should be new is what I'll call population bioethics. Here, think of the metaphor of a bird's eye view of populations, a 30,000-foot view of populations. When you take that view, you can't see individual clinical interactions between physicians and patients or physicians and other healthcare professionals. Those simply go out of focus. But you do have a broader view of populations, and in particular, you can now see what's affecting their health. You can see how their health varies across populations, either within a country or across countries. You can see what's causing inequalities. You have to have really good vision on this, but you can see what's causing inequalities in their health. And you can see ethical issues arising across populations. So you're going to see different things with this population view. Now, what are some of the hallmarks of what I've called population-level bioethics? Well, one is a focus on health, not just health care. Clinical bioethics has tended to focus on health care, not health. Health care, as all of you should know, and probably nearly all of you do know, health care is responsible for only a minority of the longevity gains over the last century. It doesn't have as big an impact as I guess I like to think before I started reading in this area. So if we're considering health and a focus on health, then what we have to do is look at all the determinants of health. And these include not just medical care, but socioeconomic class, big factor, environmental and working conditions, education, social exclusion, and if I wanted to add more, it would be easy to do so. The other thing about focusing on health is that it naturally takes a global focus. especially in the developing world, where, of course, health is worse. The burden of disease is greatest. And it draws on different disciplines than traditional bioethics has. Draws on disciplines of demography, gerontology, genetics, economic development. What's interesting, especially to a philosopher like myself, is that the areas of moral philosophy that it draws on are different than traditional clinical bioethics. The central moral value that arises for the issues in this population level approach is social justice. So it shifts the moral focus, excuse me, shifts the moral focus from personal and individual morality, how should I treat another individual, to political philosophy. Excuse me, and theories of justice in particular. So, I'm going to be talking today about bioethics at the population level. So what are some of the issues, the central ethical issues that arise from this population perspective? I'm going to illustrate an answer to that with some of the central issues to give you a sense, at least, of both their nature and their scope. I don't have time to explore in any detail, and I won't even be able to mention all of them. I hope to interest some of you to do that, but even if I don't, at least to make you more likely to notice these issues and understand that they're just as much a part of bioethics as the traditional clinical work. They're just as important. And what does it mean to say they're just important? Well, the ethical issues are just as important. The injustices can be just as great at the population level, and the impact on people's health is just as great. So let's start with social determinants. A lot of you know, I hope, about the Whitehall study done in the 1970s by Michael Marmot. It was a study, it was called the Whitehall study because it was done with individuals working in the British Civil Service. It was actually a study initially of cardiovascular disease, but they found something quite interesting and quite unexpected. As you went up each rung in the civil service, and the rungs were well defined, it's a bureaucracy after all. As you went up each rung in the British Civil Service, life expectancy increased, even when you went from the next to highest rung to the highest rung. Now they had controlled for things like smoking and so forth, and everyone had access to health care because the National Health Service had been in place for some time. So there was an interesting question of why is this happening? It was an unexpected finding, and so the next step is to try to explain it. Well, there's more controversy about what the cause is, but the leading explanation remains, I think, today, a combination of the effects of long-term stress and the effects of the degree of social supports that individuals have. Now, someone might object, well, look, sure, it's too bad that things work this way, but inequalities have always been with us. Social inequalities have always been with us. They always will be with us, and I accept both of those things. But it may be possible, if we can understand the biological path from the social condition to the effect on health, we don't necessarily have to get rid of the social condition, that is the inequalities. It may be we can intervene at some point along that path without being able to get a society that has no inequalities. So this is something we ought to attend to. Social determinants, again, let's come back home to Washington. Michael Marmot again pointed out that if you get on the metro in Anacostia, a very poor part of Washington, D.C., and you get off at NIH, life expectancy has risen 1 year for each stop that you have on that ride. Now, that's the effect of a lot of social determinants. Racial prejudice, Anacostia is a largely black community, poverty, education, violence, and so forth. Still, one might ask, well, why is there such a big effect of these social determinants? And one of the things I like to point out as at least part of the answer to that, to make it intuitive to people, I mean, the degree of the effect is an empirical question. It either is that effect or it isn't. But social determinants largely affect the incidence of disease. They affect whether people get cardiac problems or any other problems. Medical care, unfortunately, and one says this even in a medical school, is quite imperfect in being able to treat those conditions. So if you get a lot more incidence of the diseases, you're going to have a bigger effect because of the inability to successfully treat those diseases. Well, what should we do in the face of this? Well, one of the things we should do is attack the social determinants of health. Notice the things that I have on the slide: racial discrimination, poverty, poor education, violence. Those are all things that we could quite reasonably want to get rid of or reduce in our society. So we can attack the social determinants of health, and we can also focus prevention and medical care in areas where we know there's a big effect from these social determinants. Different issue, but all part of this perspective that I think you'll get from the population perspective as opposed to the clinical. Society's responsibility for health. In the 1980s, there was quite a trend to privatization, in part pushed by the so-called Washington Consensus, pushed by the IMF and the World Bank. It pushed towards privatization in the sense that the responsibility was being shifted from a social responsibility to a privatized responsibility. And large increases in the cost, I don't need to tell any of you about that, have led to beachheads of privatization, even in some developed countries. In the United States now, over 40% of healthcare is still paid for, over 40% of all health expenses are paid out of pocket by individuals. So we have this too. So the issue that arises here is, what is the case for the assumption of responsibility for health by the state? I think that's in part a moral question, although there'll be some empirical components to any answer. And in particular, what form should that responsibility take? We're now developing the form of an answer to that in Obamacare. I take Obamacare not to be a pejorative, so I'll use it. There's also personal responsibility for health, however. We know that poor health is often the result of a lot of things we would like not to have. Unhealthy behaviors, poor diets, lack of exercise, tobacco and substance abuse, excuse me, failure to comply with medical advice. Now the question is, what are the implications for health policy? Well, one answer would be paternalistic bans. Mike Bloomberg's ban on large bottles of soda that have a lot of sugar in them. That would be one way to try to respond to the unhealthy behaviors. A controversial way, and certainly not what it would probably be unpopular to have everyone have to turn out for morning exercise. Would be unpopular with me, at least. Now, another interesting question here is, when should the fact of all these unhealthy behaviors affect care that's covered in the health service, whether you get care? It was an interesting poll done in England a decade or two ago, I think. The British public supported the removal by the health service of conditions that left you with blemishes on your face, but on the other hand, they did not support the health service removing tattoos. Why? Well, I think the answer is probably that the tattoo was your own fault. You don't have to get a tattoo. Live with it, or it's not a social responsibility in any event. In West Virginia, there was a Medicaid experiment where individuals in the Medicaid program were offered additional services if they engaged in a number of healthy behaviors, a number of health monitoring cases. So we could give people more when they act responsibly and give them less when we think they haven't acted responsibly. One general issue here is when should personal responsibility for health affect the costs that individuals bear for care? And again, some insurance companies charge higher health rates for smokers, just to give you an obvious example. A little bit more on personal responsibility. Many healthy behaviors are disproportionately concentrated in the poor. Smoking is a good example, but there's a lot of others. Well, how should we think about this? Is this a result of personal failings of the smokers? Or is this a social injustice? Is the fact that more smokers are poor another injustice that comes from their being poor? And there's a very broad question here, which I think is interesting, namely, to what extent, if any, should concepts of desert, what people deserve, of fault, of blame and responsibility, have a place in the health field? At the health and should they have a place at the health policy level? Should they have a place at the clinical level? The norm in clinical medicine is that they shouldn't have a place there. The norm in clinical medicine is that physicians treat patients' needs, and they don't evaluate whether the patients deserve care. Yet these other examples that I've given you concern evaluations by the general public and so forth of whether patients deserve care, the tattoos versus the congenital blemishes. And public health goals also typically don't look to whether patients, whether individuals deserve interventions or don't deserve interventions. They look to what we can do to improve public health without making use of these concepts of desert and blame and so forth. Another issue, health measurement. Evaluating the health needs and the health benefits of interventions requires health measurement. And not just measurement of the health of an individual, clinicians do that all the time, but of populations. Now, fortunately, in 2000, well, it's called the 2010 study. It just came out in the Lancet earlier this year. But the 2010 Global Burden of Disease study provides a comprehensive measurement of burdens of over 200, the health burdens of over 200 common diseases over different regions of the world. It's an enormously ambitious study. It's a redoing of the 1993 study of the World Health Organization and the World Bank, but of course with much better data now and much better methodology than was available 20 years ago. That gives us a lot of information which can be used for thinking where should priorities go. In the 1990, to give you an example from the 1993 study, the 1993 study put depression much higher on the map in terms of the burden of disease it created. Why? Because previous studies of that sort had focused on mortality, and the main effect of depression is not mortality, it's morbidity. And depression became a higher priority condition to be treated. So we have available now data that we didn't have to address some of the questions I'm talking about. More local and detailed measures arise from people working in particular areas. Just to name my department chair, Paul Farmer, Partners in Health can provide us with information about the burden of disease, for example, of cholera or HIV in Haiti. Another issue, universal coverage. In the WHO 2010 World Health Report set the goal of countries achieving universal coverage. And in developing countries, not just developed countries like the US. But most countries then are going to do so with very limited resources. So what are some of the ethical choices that they face in trying to achieve this? And many countries around the world are in the process of trying to achieve universal coverage. These will also be choices that we'll face in the filling out over time of the content of Obamacare, what it does cover, what it doesn't cover, how it covers it, and so forth. Now this, if I can see it, this is WHO's cube. And there's a cube, and then there's a cube inside. The blue shows you what current pool funds cover. Who's covered in the population, which services are covered, and direct costs, which of the costs are covered. So not all the costs are covered, not all of the possible services are covered, not all of the people are covered. I don't have much practice with using these. Philosophers don't tend to use pointers very often. There are trade-offs there, right? If you cover more people, then somehow you've got to cover fewer services. If you want to cover a larger proportion of the direct costs, then that has to come from one of the other areas. One of the things I became aware of in work that Dan Wickler and I did in Thailand was how important the coverage of the costs and the prevention of large-scale bankruptcy, which is a big factor in this country, and just destitution of large extended families from uncovered health expenses. So it's an example of the trade-offs, which I think illustrates it nicely. Priority setting and cost effectiveness. Scarce resources, and the economists are right to tell us they're always scarce, they require priority setting for drugs, for healthcare interventions, and services for individuals or groups or types of patients, and for research for that matter. We can't do in any of those areas everything that there might be some reason to do if resources weren't scarce. Cost-effectiveness interventions, the cost-effectiveness interventions tell us which interventions will produce the greatest health gain with the resources available to us. So that's basically an efficiency kind of calculation. It tells us if we only have this much money, how can we produce the greatest health gain? Now, I didn't deliberately put a higher font on the next point, but it deserves it, in my view. Cost effectiveness ignores issues of equity. I'm going to take the time only to give you one example. And issues of equity that ordinary people care about. So issues that make ordinary people very uncomfortable with simply using the results of a cost effectiveness example. If you recall in the first decade of this century, the World Health Organization had a 3x5 program. The aim of that program was to get 3 million people with who were HIV positive on antiretrovirals by 2005. That was an overly ambitious goal. They didn't come close to meeting it, but nevertheless, that was the goal. Now, the problem, in part, was that they estimated there were 6 million people in the world not on antiretrovirals who could be benefited by getting on them. So even with the ambitious goal of 3 million, they had to choose among 6 million as to who should get it. Now, if you simply use cost effectiveness, or you said, we want to get as many people as possible on antiretrovirals, Norm Daniels and I were both at a meeting at WHO where this was discussed. And one of the things that you would decide, I think, is that you would only aim at treating urban patients. Why? Because they were cheaper to treat. You could more effectively treat them in the sense that they were densely situated, so you didn't have to go way out into the countryside. And of course, there were more health facilities to support the program in urban areas. So you would simply say you wouldn't say it explicitly, I suppose, but you would in effect be saying to the rural patients, too bad, we don't have enough to treat everybody, and we'll get more people treated if we just concentrate on urban patients. It was sometimes said, and I would have said, that don't the rural patients deserve at least some fair chance to get their needs met? Or should we just exclude them because it's inefficient to try to get them. That's one now, the some fair chance, I mean, fair is in there deliberately. That's a moral notion. I take it that that's obvious to everyone. With priority setting and cost effectiveness, there's a broader question of what moral assumptions are embedded in cost effectiveness analysis, both in the methodology itself. Here I'm not really going to, excuse me, explain in any detail these examples, but a temporal discount rate, which economists always put into a cost effectiveness analysis. So it says that if you get a gain right now and you get the same amount in 10 years, getting it in 10 years is worth less than it is getting it now. Or if you can avoid paying until 10 years from now the same amount that you would have to pay now, you need fewer current dollars to pay in 10 years. If you use a temporal discount rate, which is standard in cost effectiveness analysis, what are some of the implications of doing so? Well, one implication is that preventive services are going to be systematically undervalued or systematically disadvantaged in the analysis. Why? Because preventive services are often interventions we do now, a vaccine we do now, a behavior change we do now, and the benefit comes some 20 or 30 years in the future, as opposed to acute care interventions. Now that's not a, so it's controversial whether you do discounting. In my view, you shouldn't, but I haven't given you any argument for that. But it's an example of something that looks like an economic issue, but in fact is quite clearly in part a moral issue as well. There's also a set of issues when you get the results of cost-effectiveness studies and want to use them, then they come into conflict with ordinary ethical issues that ordinary people have. Shouldn't we give some moral importance to how badly off people are? Shouldn't there be some priority to the sickest, for example? And if you do empirical studies that have been done, ordinary people want to have some priority given to the sickest, even at some cost of the aggregate health gains that you get. And then there's, okay, if you have these ethical issues and you don't want health policymakers to simply ignore them, what happens sometimes is the economists bring in the numbers that they've gotten from their cost-effectiveness analyses, and they say, this just tells you what will give you the greatest health benefit. Of course, you have to take account of the ethical considerations, Mr. Policymaker. And if that's all it said, you can imagine how often the ethical considerations get much attention. So there's a question of how you can make the ethical issues get more attention and how you can help the policymaker to give some weight to them. One strategy is to try to put the ethical considerations, integrate them into the numbers of the cost-effectiveness analysis for varying reasons which I won't go into. I don't think that's a promising strategy. Another strategy is to try to provide usable explanations to policymakers of what those issues are and how they affect the policy choice being made. Global health inequities. Morbidity, and this is something that's much more obvious than it was 10 years ago or 20 years ago. Morbidity and mortality differences between developed and developing countries are enormous. There are over 30-plus gaps in healthy life expectancy between many developing countries and typical developed countries. There are also huge differences in the resources they have available for health. As you know, we spend roughly $8,000 per person on health in this country. Significant portion of that wasted, but still. In many developing countries, they spend less than $100 per person per year on health. And in some of the poorest developing countries, the numbers are $20, $30, and so forth. Now, of course, you can imagine that that's got to buy a lot less. The World Health Organization has tried to identify essential resources, which if you're only spending something like $50 per person, where should those resources go? There's also a similar gap in research, something that's known as the 1090 gap. I'm not sure if that's closed at all. As far as I know, it hasn't closed much. The 1090 gap simply says that only 10% of the health investments in research are directed at what causes 90% of the global burden of disease. Or you can put that differently. I don't need to put it differently for you. The idea is there's a huge mismatch in what we're spending research dollars for and what, in fact, causes the greatest burden of disease in the world. That may have been, I haven't seen recent enough data to determine whether people like Gates and so forth getting into the research field has changed that dramatically, but certainly the gap hasn't reversed. Let me say a bit more about global health inequalities. What's the nature of the injustice in the inequalities that I just mentioned? It might just be the unjust causes of those. For example, if you think of Africa and Europe, the unjust causes of these would include colonialism, imperialism, unjust terms of trade, monopoly powers of global corporations, et cetera, et cetera, et cetera. Now that might be one explanation of why you thought these disparities were unjust, because they had unjust causes, and they certainly significantly do. They might also, you might have the view that they also are unjust independent of these unjust causes. So it raises the question whether disparities of the sort I just gave you examples of that don't arise from injustices, but from, quote, natural causes, are they still unjust? There is some tendency in some work in health policy to think there's no difference between inequalities and inequities. That is, that all inequalities are also inequities and unjust. This question, this bullet questions whether that might be the case. And so the question is, are there grounds for treating health disparities as special and different from other disparities, such as income? We don't think all income disparities are unjust, certainly some are, but we don't think most of us don't think all are. Should we think the same with regard to health? I've been talking just now about global health equalities. Let's talk about US health inequalities, rather. Inequalities in health, even in developing countries, are much greater than is generally realized. And what illustrates this best, to me at least, is the following. It's a little tricky to say it, but in the US, life expectancy differences between counties that have the combination of the worst poverty and the highest inequality. So if you compare those counties with counties that have the lowest poverty and the least inequality, then the difference in life expectancy is greater than the combined effects, you can read the slide, of lung cancer, diabetes, motor vehicle crashes, AIDS, suicide, and homicide. Now, the combined effects of all of those are big. And what that means that even in a country like the US, the impact of these inequalities are huge. So what gets raised here is there are lots of ways to measure inequality, and lots of different interventions can produce different impacts on those inequalities. So what it raises is what patterns of health inequality are most morally objectionable. I'm not suggesting that we're going to get rid of all health inequality, but if we want to think we're moving in the right direction, then we have to know which patterns of inequality are most objectionable or least objectionable. And how do we measure all this stuff? Can we use economist measures that they use with measuring inequalities in income, Gini coefficients, and so forth? I've already mentioned the second bullet. And should there's a question that if I had an extra 10 minutes, I'd love to illustrate, but should the ultimate goal be equality in health prospects between individuals, or should it be raising the prospects of those with the worst health, those who are worse off? Now, those are different goals, and they can come into conflict. And if you'd like to, any of you would like to ask me in the discussion, how are they different? I'd love to answer. Question of bioethics and human rights. And what's the relation of human rights discussions and human rights talk to population-level bioethics? Health and human rights are now fairly ubiquitous and official. The various international organizations, including the World Health Organization and others, appeal to arguments based in human rights. Now, bioethics outside the US draws very heavily on human rights. Well, you have a right to light. You can still see the slide, so that's fine. Bioethics outside the US draws heavily on human rights talk and human rights frameworks for thinking about bioethics issues. Bioethics in the US generally does not. There's a group down at BU, George Annis and his friends there, that use a human rights framework for most of the bioethics work they do. But that's not typical in this country. So are the same issues being addressed by people who think in human rights terms and people who think in the traditional bioethics terms that you hear in this country? That's an open question. I think bioethics, human rights talk can be very helpful for some questions, my own view is, and not for other questions. For example, it's not very helpful for prioritization and rationing questions, in my view, but it can be very helpful for other questions, for example, of discrimination. So would it be useful to try to integrate these two fields? There's a lot of work being done in each area, but they're usually by different persons, and the work isn't integrated. And if it would be useful, how do you do it? How do you bring it about? It's not easy to do. Health and economic development. The WHO Commission on Macroeconomics and Health, now about 15 years ago, I guess, argued the case for health investments, in particular in developing countries, but in general, for their economic benefits, not just their health benefits. Now that seems to imply that a country concerned with both health and economic development, and that certainly is true of probably all countries, but especially developing countries, where economic development is more important. A country concerned with both health and economic development should weigh both effects in resource allocation. This seems to imply as well, however, a different priority to investments that give you equal health benefits, but that have different economic impacts. For example, it seems to imply lower priority to health investments for the elderly, the disabled, the unproductive. They don't give you the same economic benefits. That is pretty sharply in conflict with physicians' clinical practice, which is to ignore their patients' social value or worth in this sense, and attending only to their medical need. So are these practices what the Macroeconomics Commission recommended and what physicians do? Are they in fact inconsistent? If they are, which practice is ethically justified? Or is there some justification for different practices at the macro level, where you're making health investments, say a country's making health investments, as opposed to the micro level where you're treating individual patients? Sorry, someone was drinking and I thought it was a question. There'll be time for questions. More generally, can bioethics contribute anything useful to deliberations about what share of national resources should be devoted to health? And there have been pronouncements by WHO and others about what proportion should go to health, but it's never exactly clear to me, at least, what the rationale for those pronouncements are. Another issue, you see they just keep coming. Distributing the burden of risks. What should be the standards for allowing or permitting behaviors or conditions that cause health risks to others? A couple of recent examples, the explosion in Texas, the collapse of the factory building in Bangladesh. The common economic answer to this is what's called willingness to pay. The willingness to pay of those who are at risk to avoid it, the willingness to pay of those who would be imposing the risk. And the California case, which I got from Dan Wickler, concerned evidence that people would pay more to be able to talk on their telephones while they drove, creating a risk to others, than pedestrians would pay to avoid the risk. And so a couple of people got run down, a couple of migrant workers got run down. Now, as I'll mention on the next slide, that was justified by, not the running down, but the policy, was justified by willingness to pay arguments. But of course, those who were run down didn't get compensated for the fact that they lost the argument. Willingness to pay is influenced by income distribution. How much you're willing to pay for anything is determined by how much resources you have. But that income distribution is often unjust. So it's not clear that willingness to pay then gives you just answers to how to distribute the burden of risk. The economic rationale for willingness to pay is that it's welfare maximizing. But it's not clear, as I said a moment ago, it's not clear that the fact that it's welfare maximizing is just if, I'm always using just as the ethical word, not just in the sense only. It's not clear that it's just if no compensation is paid to the risk bearer. And if willingness to pay is not, as I think it is not, an ethically adequate standard for risk imposition, then what is? A related issue, environmental equity. Most of us don't suffer a lot of environmental risks that the worse off people in our society do suffer. They're very unevenly distributed across the population. The poor, not the rich. I imagine there's almost no one here who lives very near toxic waste dumps, polluted water, and so forth. There's certainly people who are poor are more disproportionately subject to that. The rich can avoid that. They can pay to avoid it. The poor also often don't benefit proportionately from the activities which create these risks, the industrialization that causes those hazards. Now, one could say, well, too bad. This is just another burden of being poor. Or we could ask, is there a special moral reason to achieve at least a more equitable pattern of immunity from these threats to health, since the threats obviously can be very great? Climate change is probably, the environmental issue that's on everyone's mind these days, should be anyway. And climate change requires global coordination, obviously, to take the steps necessary to deal with it. Climate change, we now know, will have a very disproportionately adverse effect on the poor, on the health of the poor. So what's the responsibility of the globally advantaged countries to protect the global poor, given that they are more at risk? And I think what's very interesting here is what institutions will be needed to do so, since individual countries can't carry this out on their own very effectively. Now I'm getting near the end, but not quite. Population and genes. Well, historically, the eugenics movement, especially those of us who are older can remember some of this, sought to improve population health and well-being through heredity, through determining who procreated. That goal was deeply discredited by the abuses of the Nazis and others. There were some bad programs in Scandinavian countries, in the United States, and so forth, but the Nazis, so to speak, took the prize. Advances in genetics now have given us new abilities to pursue this same goal of producing a healthier population. Prenatal genetic screening for disease, PGD, and so forth. Now the question is this goal ethically unacceptable if it's dissociated from the past abuses that came with the Nazi programs and with others? I have in mind discrimination against ethnic and national groups that wasn't justified, the coercion that was part of the early eugenics programs, and so forth. So if we could just think about producing a healthier population without all of those aspects that the Nazis gave us and some of the other countries gave us, would we still have a negative view of the use of genetic technology to improve the health of the population that gets produced? What lessons, you ask this, what lessons should we learn from the history of eugenics? What goals, values, standards, practices would we be discussing without this history to contend with? Because what often happens is somebody says that's eugenics, and that's intended to be the end of the discussion. It's an unrelated point. Genetically homogeneous populations can have a lot of research and commercial value. Genetically homogeneous populations are often isolated populations, relatively small, where there hasn't been a lot of movement in and out of the population. These populations are often poor and vulnerable, but yet, nevertheless, they can have value to researchers. Are they being exploited by their use in research and subsequent commercial development? And if so, how can that be avoided? I'm very sensitive to global aging because I'm aging too, as we all are. But it's obviously a worldwide phenomenon. It's getting increasingly worse. There are changes both in the size of birth cohorts over time, as well as in the old-young proportions from living longer. The distribution of country resources generally go more towards, or they're skewed towards, the old as opposed to the young. We hear all the time we spend too much on the old, we should be spending more for children. Why do we spend so much more on the old? Probably because they have increased political power. In this country, they vote much more often than the young, and so forth. So the question that arises here, Norm Daniels has written extensively on this, are there ethical principles for just distributions of resources between the young and the old? It's not to say that if we could agree about what's just, it would be easy to bring it about, but at least we'd have some idea of the direction in which we wanted to go. Protecting health, endangering civil liberties. SARS and bioterrorism were two of the most recent threats to public health from infectious disease. We now have a good example here in Boston that wasn't bioterrorism, but explosive terrorism. Each of these threats from bioterrorism caused a lot of public fear and panic, and a variety of public health and public policy responses. SARS mostly in China, but also in Canada. A lot of those responses endangered or at least limited civil liberties from what they would otherwise have been. So the question here is, what sacrifice of civil liberties should we be prepared to accept to protect public health from threats like this? For example, quarantines were used in Cuba for HIV/AIDS. Quarantines were used in China for SARS. And I think the interesting question, especially here, is should the balance between public health and civil liberties change when the threats aren't short-term epidemics, as SARS was, but rather relatively permanent threats like bioterrorism, what we believe we face now. Should we change this if we think this isn't going away? So if we if we accept a new balance and accept more limitations on civil liberties, that's not a short-term response to a disease. That's a long-term response to probably a long-term problem. And there's an issue of what we should accept, limits we should accept just because we want to reassure the public as opposed to what will really do the job. Okay, so there's a fascinating paper, which probably a lot of you know, by Jeffrey Rose, looking at the practice implications of this population perspective. He didn't call it that, but that's what it was. The medical versus the population approach to risk factors for disease. In the medical approach, what you do is you do what physicians here do. You identify high-risk individuals, those who have elevated, those who have hypertension, and you treat them. Population approach works differently. You reduce the risk of the population as a whole, and usually with non-individual and non-medical interventions. So we used to think, until the New York Times told us differently a week ago, that we should have less salt in the diet, right? So we try to interventions which would produce less salt in the diet. Now these are complementary. You don't know, it's not as if you have to do one and you can't do the other. But the question still is, what considerations should determine the relative emphasis that we give to each of these? And in particular, are there ethical factors besides simply the relative effectiveness of the two ways of approaching these health problems? Is the medical approach more respectful of choice? It tells a patient he's got some problem, and it's up to the patient to choose to take whatever intervention would help it or not. Does the population approach impose interventions on individuals not at risk? Well, the answer to that is clearly yes in some cases. But is the population approach more equitable by reducing everyone's risk equally as opposed to selecting some? And does one of these approaches contribute more to the medicalization of everyday life, contribute more to people like Mayor Bloomberg, who wants everything that we do to be healthy? One might favor one or the other approach for efficiency considerations, effectiveness considerations. One might also favor one or the other for ethical considerations. I've talked about the research ethics issues a bit already, and they have gotten a lot of attention in current medical ethics. So I'm going to leave them aside here for reasons of time. But I want to say something before I finish up on health system reform. Obviously an issue in this country. We're undergoing it as I speak, and as you will speak in the question period. Health systems around the world obviously differ very greatly. They differ in their structure, but in particular, they differ in the ethical deficits that they have and the strengths that they have. And so a very broad question is, are there norms to guide reforms of these systems in the direction of greater justice? And there's two kinds of norms that we would want here. We would want procedural norms of the sort that Norm Daniels has written about a lot. Public participation, transparency, reasons being given for why we're doing it this way as opposed to that way. We'd also like substantive norms for those efforts for healthcare reform. We certainly don't have substantive norms that there's any consensus about. It would be nice to please get us some. So let me come back to the overall topic. What's distinctive about population-level bioethics? Well, one thing that's distinctive is it draws on intellectual resources. Here I'm going to repeat a number of things just for emphasis that I said at the beginning. Within ethical theory, the primary resource is social and political justice, political philosophy, and especially theories of justice. Questions of individual conduct have much less significance on these issues. Vices and virtues of individuals, questions of character, are also secondary. Quantitative training is important for people interested in working on these problems. That means statistics, economics is an asset. I think all of those should be part of the training of people who want to work on these questions. Not just because I had a BA in economics. Anything I learned as an undergraduate in economics is so far out of date that it's not much use to me at this point. So population level bioethics directs our attention to a different set of controversies and unsolved problems. And there's an emphasis on which and when inequalities that get produced, in particular health inequalities that get produced, are justified. How do we compare and rank distributions of health? Do we look at the ratio of the top and the bottom deciles? Or there's a zillion other ways we could do that. Or is the issue, as I said earlier, how bad the worse off, not what the relative pattern of inequality is. Population bioethics also speaks to different audiences. And you might ask, well, why are you talking about it here in the medical school? Because it speaks mostly to those with the responsibility for population-level decisions, less often to individual patients and clinicians. So it has different academic neighbors as well. Substantial overlap with economics, in my view. But others include demography, history, sociology, political science, decision theory. And population-level bioethics is, I think, inherently global, not just for purposes of illustrations, but because if you're looking at the health of populations, you inevitably are not going to be restricted by national boundaries. So here's the conclusion, last slide. And given, I'm right at 60 minutes. The bird's eye view brings a whole range of new questions affecting health into focus. And it brings a whole range of new ethical issues, mostly issues around health inequalities. These population level issues, you're going to read this, but I'm going to read it to you too. These population level issues should not displace traditional medical ethics with its clinical focus. That would be a foolish view, I think. But they are at least as important for people's health and for the ethics of health, and thinking about who gets what by way of health. So they need the attention that they have not generally gotten. And so those of you who are young enough to still have your careers ahead of you, I urge you to work on these problems. Thank you. Thank you.
Going to make it be like Stephen Colbert here and quiet down the audience.
I'm not nearly as funny.
Well, you've certainly made a great argument for why this should